the Center of Hepatology. Now we would like to start the postgraduate course, Hepatitis B. This session will be chaired by Professor Jinlin Ho and Professor Osamu Yokosuka. Moderators, please start.
Good morning, and I'm Dr. Yokosuka, and I'm going to co-moderate with Professor Jinlin Hao. You are from
Good morning, everyone. Thanks.
Well, this session is about hepatitis B and about the situation of hepatitis B and Dr. Batakuru speak about a little bit about hepatitis C in Mongolia, and then Dr. George Rao talk about the situation of hepatitis B virus infection in Asian Pacific region, and then the last speaker will talk about HBV core-related antigen and the significance about that. And I will introduce our first speaker. First speaker is Professor Wan Lon Chuan, and he is a chair professor of Hepatobiliary Division, Department of Internal Medicine, Kaohsiung Medical University Hospital in Taiwan. And he was graduated from Kaohsiung Medical University in 1980 and studied in here Japan from 1991 to 1992. And he got a PhD in Kaohsiung Medical University in 1993. And he is chief of Hepatobiliary Division, Department of Internal Medicine, Kaohsiung Medical University Hospital. And he was president of Taiwan Association for the Study of the Liver from 1910 to 1911. He got the award for outstanding contribution in science and technology, Executive UN Taiwan 2009. And he also received Distinguished Research Award, National Science Council Taiwan 2011. And especially, he was awardee of Lesmana Solano Great Mentor Award, APASU 2019. And he's going to talk about chronic hepatitis B virus infection. Please, Professor Chan.
Thank you, Professor Yokosuka, for your kind introduction. Good morning, Mr. Chairman, dear colleagues. First of all, I would like to thank Professor Sina for inviting me to give a talk. My topic is chronic hepatitis B virus infection. I have nothing to declare. Chronic HBV infection is a serious health issue affecting 250 to 300 million people worldwide. According to the estimation by WHO, hepatitis B resulted in 820,000 deaths in 2019. Chronic HBV infection might lead to liver cirrhosis, hepatic decompensation, and hepatocellular carcinoma. Approximately 15 to 40% of patients with chronic hepatitis B will develop liver cirrhosis and hepatocellular carcinoma. Since 1985, the natural history of chronic HBV infection was proposed to comprise three phases, defined as immune tolerant phase, immune clearance phase, and inactive residual phase. The first phase, immune tolerance phase, is defined by E antigen positive, very high HBV DNA and HBsAg levels, with persistently normal ALT. The transition from the immune tolerant to immune clearance phase usually occurred between the age of 20 and 40. Patients in the immune clearance phase have high HBV DNA and HBsAg levels with elevated ALT. After seroconversion, most patients enter the inactive carrier phase with persistently normal ALT and low HBV DNA and HBsAg levels. However, 10 to 25% of inactive carrier might progress to e-antigen negative chronic hepatitis B. The e-antigen negative chronic hepatitis B is characterized by absence of e-antigen, fluctuating HBV DNA, and elevated ALT levels. Therefore, a fourth phase, e-antigen negative immune active phase, was suggested. The e-antigen negative immune active phase was considered to be a reactivation phase following the inactive carrier phase. However, the reactivation phase is similar in every aspect to the immune clearance phase, except for the e-antigen status. Thus, the reactivation phase could be a variant phase of immune clearance. If we compare the characteristics of e-antigen negative chronic hepatitis, e-positive chronic hepatitis, and e-negative chronic infection, the HBsAg and HBV DNA levels of e-antigen negative chronic hepatitis are between the e-positive chronic hepatitis and e-negative chronic hepatitis. The elevated ALT, severity of liver disease, and the severity of disease progression are similar between e-antigen negative chronic hepatitis and e-antigen positive chronic hepatitis. The e-antigen negative chronic hepatitis might develop directly from the e-antigen positive chronic hepatitis after e-seroconversion. In addition, the incidence of reactivation in inactive carriers was not so high in cohort study. Therefore, is this e-antigen negative chronic hepatitis just a phase between the e-antigen positive immune active phase and inactive carrier phase? If so, we can merge the e-antigen positive and e-antigen negative immune active phase as one phase. Spontaneous S-antigen seroclearance may occur in patients with chronic hepatitis B. The spontaneous annual S-antigen seroclearance rate is around 1 to 1.5%. The cumulative incidence of spontaneous S-antigen seroclearance was highest in inactive carrier, 36% in 20 years. The patient who clear S-antigen will enter a phase of resolved or acquired HBV infection, being SAG negative, anti-HBC positive, with or without anti-HBs. The last phase of chronic hepatitis B was suggested as functional cure of HBV. Nonetheless, the acquired HBV infection might still have HBV in the blood. HBV reactivation could be found in the resolved hepatitis B patient treated with rituximab-based chemotherapy. The HBV reactivation in resolved hepatitis B patient was associated with S-antigen seroreversion. Furthermore, the resolved hepatitis B patient with anti-HBs had a low rate of HBV reactivation. The patient with higher titer of anti-HBs had a lower rate of HBsAg seroreversion. Taken together, the functional cure should be defined as S-antigen negative anti-HBC positive with high titer of anti-HBs. Therefore, the natural history of chronic HBV infection could be condensed as three phases: immune tolerance phase, immune active phase, both e-antigen positive and e-antigen negative, and the inactive phase, including inactive carrier, occult HBV infection, and isolated anti-HBC. The goal of treatment for chronic hepatitis B are to prevent transmission and to improve survival and quality of life by preventing disease progression and hepatocellular carcinoma. The international guidelines recommend antiviral therapy for non-cirrhotic adults with immune-active chronic hepatitis B. The suggestions are based on the elevation of HBV DNA and ALT levels. Patients with elevated ALT and high or intermediate HBV DNA levels are indicated for antiviral therapy. The treatment for immune-tolerant patients and inactive carriers is not recommended. Patients with compensated or decompensated cirrhosis should be treated regardless of ALT, HBV DNA levels, and e-antigen status. PEG interferon and nucleoside-nucleotide analog are the first-line agent for chronic hepatitis B treatment. The E-cell conversion rate in e-antigen positive patients are around 20% by 2 years or 3 years of nuke therapy, but the rate of S-antigen clearance are only 2 to 5%. The E-cell conversion rate by PEG interferon for 1 year is about 30 to 35%. For non-cirrhotic e-antigen positive patient, full cell convert to anti-HBe. International guidelines suggest that discontinuation of nuke can be considered following a period of treatment consolidation. The rate of HBV DNA suppression can be achieved as 90 to 95% by nuke therapy in e-antigen negative patients, but the rate of functional cure was less than 1%. The real-world data from Asian countries also reveal a low rate of functional cure by nuke therapy in e-antigen negative patients. Therefore, the ASL guideline for nuke treatment recommend to treat indefinitely until S-antigen loss in inactive chronic hepatitis B patient. Surprisingly, increasing rate of HBsAg loss were observed after cessation of nuke treatment in e-antigen negative patients. The annual incidence of S-antigen loss was 3 to 6% after finite nuke therapy. According to the tremendous result, the APOSTLE and ESOL guideline suggests that stopping nuke therapy can be considered after 2 to 3 years of treatment with undetectable HBV DNA and having a careful monitoring plan. Retract B study is an international cohort study on off-therapy response after nuke withdrawal in 1,500 patients with chronic hepatitis B. The treatment duration was 3 to 4 years. The median duration of follow-up was 18 months. The results show that the cumulative probability of HBsAg loss was higher among whites as compared with Asians. The 4 years of therapy, S-antigen loss probability in Caucasian were 41 and 5% if the cutoff point for HBsAg at the end of therapy was set as 1,000 IU. On the other hand, the 4 years of therapy, S-antigen loss probabilities in Asians were 33% and 2% if the cut point for HBsAg was set as 100 IU. So the HBsAg label for consideration of nuke withdrawal were recommended as less than 100 1,000 IU for white patient and less than 100 IU for Asian patient. Although the cumulative probability of S antigen in the retract B study was 13% at 4 years of follow-up, high rate of virologic relapse was found. The cumulative probability of clinical relapse was 55%. This result led to nuke retreatment in 55% of patients at 4 years of follow-up. 19 patients developed hepatic decompensation after nuke cessation. 8 occurred in cirrhotic patients, and deaths occurred in 7 of the decompensated patients. In this retrospective study from Taiwan, 830 patients who discontinued nuke therapy were analyzed. The cumulative incidence of severe AE following cessation of antiviral treatment was 1.1% per year, and the 10 years cumulative incidence was 19% in cirrhotic patients. Despite retreatment, 7 of 38 severe AE patients progressed to acute or chronic liver failure. Therefore, discontinuation of nuke treatment for patients with liver cirrhosis is not recommended. If hepatic decompensation develops after discontinuation of nuke treatment, restarting nuke therapy should be given immediately. The E antigen active chronic hepatitis B patient with off-nuke virus dominant flare, defined as ALT flare, accompanied with increase of HBsAg. Nuke retreatment is also recommended. The treatment for patients with virological or clinical relapse, the indication for naive chronic hepatitis B patient may be applied. There are several novel HBV therapeutics developed to target different processes of HBV life cycle, including entry inhibitor, CAM, siRNA or ASO, cccDNA epigenetic modifier, HBx inhibitor, HBsAg release inhibitor, and nuke or RNase inhibitor. The combination of different strategies to suppress HBV duplication, decrease HBsAg production, and activate the host immune response to HBV should be a possible way to achieve HBV functional cure. Thank you for your attention.
So,
should we answer the question?
thank you very much for your excellent presentation, Professor Zhuang. We will have 5 minutes for question Q&A.
Yes. Yes, please.
Yes.
Do you have a mic?
Right. Thank you for your lecture. It's very interesting. I have one small question about women with IVF. So, how about the HBV DNA level cutoff or the intervention compared to normal pregnant women? We do any difference between them?
For women with
IVF intervention compared
IVF,
to normal conceived women.
I think the indication for women with IVF is just as women with pregnancy. In fact, if patients have HBV DNA, we should prevent the vertical transmission. But for the cutoff of HBV DNA is considered 1 million IU per ml for HBV DNA. Above 1 million IU, you should prevent the vertical transmission. But under HB DNA less than 1 million IU, perhaps you can observe. But for my opinion, I think every woman with pregnancy should be treated with NUC.
Thank you.
Thank you.
Any other comment or questions? Well, I have one very basic question. You said that risk of stopping the treatment to patients with cirrhosis. How do you check the state of cirrhosis by their stiffness or other way? How do you diagnose the cirrhosis?
Yeah, we in fact we use the FibroScan to diagnose the liver cirrhosis, but FIPO is also be used in clinical practice.
Okay, thank
we seldom do the liver biopsy.
Yeah, and sometimes it's very difficult to diagnose cirrhosis in patients with very quiescent state of an HBV, chronic hepatitis B. So I asked. Thank you.
Yeah, in fact, I think if the patient with severe fibrosis, they should be treated as that like a patient in liver cirrhosis because they are also in the high risk of HCC development.
Okay, thank you very much.
Thank you. Thank you, Professor.
Please sit down over there.
Yes.
Maybe if you like.
Thank you very much, Professor Zhuang. Next speaker is Professor Fu. Fu is a professor infectious disease, Mongolia National University of Medical Science. He is more spent his time on viral hepatitis, HCC, chronic liver disease area, with numerous awards from Mongolia and international. Please, Fu.
Okay, thank you very much, Chairman Professor Hu. Good morning, everyone. First of all, I would like to express my sincere thanks to organizing committee of the PASL 2024, especially Professor Shochira Shin for inviting me this wonderful conference. Today, I am going to talk about epidemiology and genotype distribution, prognosis and treatment of hepatitis C virus and liver cancer in Mongolia. As you know, Mongolia is highest prevalent hepatitis B and C virus infection, especially chronic hepatitis B and C virus infection are one of the major causes of liver cirrhosis and liver cancer in Mongolia. During the last 2 decades, a series of studies were conducted on epidemiology, genotype distribution, and prognosis, control, and management, viral hepatitis and hepatocellular carcinoma in Mongolia. Also, last 2 decades, we have very successfully implemented a large scale of national program in Mongolia regarding chronic liver disease, including viral hepatitis B, C, and liver cancer. This slide shows is worldwide geographic distribution of hepatitis B and C virus genotypes, especially genotype 1B of HCV and genotype D of HBV are common ones in Mongolia, respectively. In Mongolia, is hepatitis B immunization program introduced since 1991, supported by WHO. You can see from this slide, this HPV vaccination coverage was in 28% in 1991. In 82% in 1996. Currently, is HPV vaccination coverage is 98.5% among the newborn children. Between 2016 and 2020, it was proposed to treat more than 100,000 people with letermovir combined treatment to reduce hepatitis virus infection among general population, stop the incidence by 2025, and reduce liver cirrhosis and cancer-related deaths caused by hepatitis viruses. Today, I am going to talk about 4 points, below 4 points shown in this slide. Is first, prevalence and genotype distribution of hepatitis B, C, and liver cancer among general population and acute viral hepatitis in Mongolia. Second, to compare effectiveness of letermovir treatment by genotype. Third, epidemiology and prognosis, clinical features, and management of liver cancer in Mongolia. Lastly, hepatitis prevention control elimination program in Mongolia. This study population 1,512 subjects and Ulaanbaatar city, which is the capital city of Mongolia, and 12 provinces. According to our study results, prevalence of HCV was 50.6%, and HCV RNA was detected 11%. Therefore, we can say that this time is prevalence, high prevalence of HCV in Mongolia. Prevalence of anti-HCV and HCV RNA had a tendency to increase with age. You can see from this table is anti-HCV and HCV RNA in the age group 31 and 4 years was significantly higher than those aged over 61 years, respectively. History of dental care, surgery, and tattooing were anti-HCV positive subjects compared to anti-HCV negative subjects. Here on genotype distribution of HCV in urban and rural areas of Mongolia, interestingly, there is no difference between urban and rural areas of HCV genotype. Most HCV infection in Mongolia is caused by genotype 1b. However, genotype 2 is very rare, less than 2% among the study subjects. Now I am going to move with how about prevalence of hepatitis B and D virus infection in Mongolia. Mongolia, its prevalence of HPV was 11.8% and anti-HDV was detected 4.8% among hepatitis B surface antigen positive subjects. Now I am going to another study, this study nationwide cancer cohort study. This study population consists of Ulaanbaatar city and 4 geographical regions of Mongolia. Prevalence of HPV of this study was 10.6%, and HCV was 9.9% among the general population aged 10 to 64 years. You can see from this table, especially during the last 2 decades, this is prevalence of hepatitis B and C virus infection has been decreased, especially hepatitis C virus from 50.6% to 8%, HPV from 11.8% to 9% respectively. Conclusion. The prevalence of hepatitis B and C virus infection has decreased from 50.6% to 8%, and HPV 11.8 to 9% among the apparently healthy individuals in Mongolia during the last 15 years. Now I'm going to move with how about acute viral hepatitis in Mongolia. Our first study was published in Journal of Medical Virology several years ago. Is prevalence of acute hepatitis B was diagnosed in 32.7%. Superinfection of HTV was 27.3%, and acute HCV was diagnosed in 6.4% among the patients with acute hepatitis in Mongolia. This study changes into proportion of acute hepatitis in Mongolia. We undertook time-trained analysis between our study published Journal of Medical Virology and current study was published Clinical and Molecular Hepatology. Aim of this study to investigate changes in the proportion of acute viral hepatitis in Mongolia over the last 2 decades. This study was conducted between 2014 and 2017. According to our study, result shows that acute hepatitis A was diagnosed in 44%, and acute hepatitis B is 29%, and co-infection and superinfection was diagnosed in 5%. This genotype distribution especially is among the patients with acute hepatitis B. All hepatitis A virus RNA positive samples, 100% was classified into genotype 1A. Regarding HPV is most common D genotype, and HCV and HTV is genotype 1B and genotype 1. This is changes proportion acute hepatitis A, B, C, D in Mongolia during the last 2 decades. Is prevalence of acute hepatitis B has decreased 33% to 29. Is superinfection D 27 to 9. Acute hepatitis C 6 to 5% decreased. This is we follow up 1 year is. Patients with acute hepatitis B is during the baseline, all 100% detected hepatitis B surface antigen. During the follow-up, after 6 months, is 7.6% acute hepatitis B was diagnosed with hepatitis B surface antigen. After 1 year, is regarding acute hepatitis B, 6.7% was detected HBs antigen. Co-infection BNT is 40% was detected as antigen. Superinfection of HTV after 1 year was detected. Hepatitis B surface antigen 94.4% among the study subjects. Conclusion: the prevalence of acute hepatitis B and C virus has decreased from 33 to 29 and C 6.4 to 5% among the acute hepatitis patients in Mongolia during the last decades. Now I'm going to briefly talk about HCV treatment. This big study published Clinical and Molecular Hepatology 2021. This study population consists of 5,028 patients. Genotype distribution of our patients was genotype 1B, 99.5%. Genotype 1A is 0.5%. 98.4% of our patients was interferon naive patients, and 1.6% was interferon experienced patients. This is result of our study. You can see from this slide this is 96% of our patients achieved RVR, and 99.6% achieved end of treatment and SVR 12 weeks. Interestingly, RVR, ETR, and SVR 12 rate of genotype 1A was 69.6%. This result is litisphere after litisphere supposed treatment, especially you can see from this figure is ALT, AST is during the baseline is ALT 80 85 international unit milliliter. After 4 weeks after treatment, ALT decreased to 36.5%, and SVR12 rate is 32.7%. During the treatment, adverse events is fatigue, headache, and abdominal discomfort is common. Now I am going to talk about how about this hepatocellular carcinoma in Mongolia. Last 20 years, cancers have always been in the second place among causes of mortality in Mongolia. This liver cancer study was published at Hepatology International in 2019. Is 85 patients consist of this study. According to 2023 national statistics of Mongolia, liver cancer was the most common malignancy, which is equal to 38% among all cancers. Most common etiology HCC patients in Mongolia is HCV, which is 46%, HPV is 34%, confection 14.4% among the HCC patients in our country. History of acute viral hepatitis, chronic hepatitis, and presence of liver cirrhosis was the strongest risk factors in liver cancer in our country. You can see from this table is over 65% of patients regarding tumor size is more than 5 centimeter. Is only 50% of patients was found single tumor. Is alpha beta protein median average is 196 nanogram per milliliter. In Mongolia, is most of patients, especially 76% of patients was diagnosed in advanced stages of liver cancer in our country. In Mongolia, liver cancer is treatment mortality very limited. You can see from this slide is only 40% of patients only receive surgical resection and their maintenance survival 90 months. Most of patients was received TAC and their maintenance survival 70 months. Regarding cause of death is 50% of patients develops HCC and 42% is liver failure. This is my last slide. Current capacity for early detection of liver cancer in our country. Alpha beta protein test is available in all areas except Intersome and some hospital. Ultrasound is available in all areas of Mongolia, and CT and angiography except Intersome and some hospital. Okay, thank you very much for your kind introduction. Thank you.
Thank you very much, Professor Batufu, for your excellent talk. A lot of data from Mongolia. Any questions from floor? Oh.
Yes, sir. Very good morning. I am Dr. Ghulam Azam from Dhaka, Bangladesh. My query about acute viral hepatitis. The main concern in our region, in Asian region, especially India and Bangladesh, hepatitis E virus. But you have not shown any data on hepatitis E in your acute viral hepatitis section. So my query for this.
Yeah. Okay, thank you very much. As you know, in Mongolia, highest prevalence hepatitis B, C, and D virus infection, especially is acute hepatitis. In Mongolia, is very common is chronic delta infection. Acute hepatitis only 5% among the hepatitis B surface antigen positive subjects in our country.
Interesting.
Yes, please.
Thank you for your presentation. So again, I'm Dr. Dian from Vietnam. So do you have any data for like some rare virus like EBV or CMV?
Pardon?
I mean, do you have the data for rare viruses like EBV or CMV from your research?
How about EB virus or cytomegalovirus?
I see.
Yeah, I'm from Mongolia as well, and we haven't done studies on EPV and
Not
cytomegaloviruses. Yeah.
Thank you.
One question, is there a screening program for early stage of HCC in Mongolia?
Okay, thank you very much. Very important question. In Mongolia, you know, is highest prevalent of HCC in Mongolia. So, in Mongolia, 2014 has approved Minister of Health HCC screening program. This program, including is every 6 months, is hepatitis virus risk factors population to check is ultrasound, and every 6 months is to test this alpha-beta protein test among this HCC risk group.
Okay, thank you. Thank you for your presentation. George is here.
Yeah.
So move back.
Hmm?
Next, George.
Yeah.
And it is our great honor to have Professor George Law next speak. George Law, a lot of you know him, former president of Apostle, currently the director of Humanity and Health Clinical Trial Center, Humanity and Health Medical Group, Hong Kong, SAR, China. He will present on HBV viral elimination in Asia Pacific region, current state and challenges. Everyone know him with numerous big papers. Also, it's very famous in not just in our region, also worldwide for hepatitis, HCC, etc. Please, George.
Thank you, Jingning and Professor Yokosuke and my Japanese colleagues and colleagues in Asia Pacific regions. I'm so glad I just to come in, just landed at Osaka and drive all the way to Kyoto. And I thought I was late, but I cashed on the time. Today, my topics for this postgraduate course is hepatitis B viral eliminations in Asia Pacific regions, and what are the current status and the challenges. And I think this is a very important topic, and I would like to share with some of my views on these important problems. This is my disclosure. I'm working at the Humanity Health Medical Group, and currently the chairman of the Humanity and Medical Health and Medical Group and chair professor at the PLA General Hospital, and also recently the Fudan University, Shanghai. This is my research interest. My drive is really in immunotherapies and liver diseases, and I've done some work in viral hepatitis and recently hepatocellular carcinoma. First, I would like to say my gratitude to my late Professor Roger Williams, who really brought me into the field. He is a great man, and I owe him a lot. He is a lifelong learner, and he always mentioned that then we become a lifelong winner. Thank you, Prof. Now, geographical distribution surface antigen prevalence in 2022, and this really helps to illustrate how important the problems of hepatitis B is in Asia Pacific regions. We harbor the majority of hepatitis B related liver mortality and morbidity around globally. And in fact, more than 70% of the death related to hepatitis B occurs in Asia Pacific regions. And we, as the Asia Pacific Association of the Study of Liver Disease, is trying to dissolve the problems and so that to benefit our patients. Having said that, hepatitis B is the major drivers for hepatocellular carcinomas and also chronic liver failures and some of the end-stage liver diseases. And it accounts for more than 800,000 new cases a year and is the fourth leading cause of cancer death, mostly due to hepatitis B and in Japan, perhaps hepatitis C. Now, the problem is the WHO has set up global hepatitis elimination targets for 2030. And the statement is really a 65% reduction of mortality and morbidity related to hepatitis B by 2030, a 90% reduction of the incidence of hepatitis B. And I'm sure a lot of you are aware of this. So where are we now? Well, this is the table we summarized and was published recently in the clinic liver diseases. We are witnessing 1/3 declines in all age prevalence of surface antigen because of the success of universal vaccinations and also the additions of NUCs to those pregnant mothers with high viremic load. In fact, this translates into nearly 80% declines in prevalence in children less than 5 years old, as shown in the tables here from 1990 to 2019. Well, this is a success. But then when we talk about mortality due to hepatitis B, we target at the 65% reductions by 2030. Unfortunately, when you look at the curve, what is happening right now is really does not translate into these directions. As you can see here, the death due to hepatitis B-related hepatocellular carcinomas and end-stage liver cirrhosis is actually on the rise instead of coming down. So perhaps we are moving away from the targets in terms of the mortality due to hepatitis B, though we have drastic reductions in the surface antigen positivity. So this is the essence of the talk. From 1997 to 2016, over 2 decades of clinical research. In fact, we have made a few changes available to our community with chronic hepatitis B. APASO, as a society, have spent a lot of efforts in driving solutions for chronic hepatitis B patients, trying to reduce our people from suffering from chronic hepatitis B in terms of liver cancers, end-stage liver cirrhosis, and acute on chronic liver failure. As witnessed here, this is the first consensus meeting in 1999 conducted in Kyoto, right here. And I was part of the members together with some of our very respected figures like Professor Kinyo Okuda and also Professor Omata, Professor Chen Jianren from Taiwan, and a few of our colleagues. Some of them have left us, but the spirits carries on. And this year is 2024, and we come back to Kyoto. Having said that, we have a series of APASO HBV consortium meetings trying to understand how we are going to deal with these problems with hepatitis B. We develop new therapies, new diagnostic methods and algorithms to treat patients and trying to translate science to our people to curtail the problems of chronic hepatitis B with this morbidity and mortality due to liver cancer and acute chronic liver failure. Well, we define the treatment endpoints of chronic hepatitis B using surrogate markers, and then which should translate into ultimate endpoints with careful understandings of the natural histories of chronic hepatitis B, especially in Asia Pacific regions. Now, these are our good old days from 1997 to 2016. Over a 20 years periods of time, so we have conducted a lot of clinical trials research, which translated into the registrations of new therapy at that time to treat chronic hepatitis B patients. And this table summarizes the anti-HBV drug approval by 2016. lamivudine, adavovir, pegylated interferon alpha-2A, telbuvudine, tenofovir, entecavir, and clavudins in Korea, and recently the TAF by the Professor Henry Chan, published in the Lancet of GH. Well, these are all big papers in New England Journal of Medicine, Lancet, and etc. And this actually brings benefits to those patients who use this medicine. The aim of anti-HBV therapies, and it is proven by the subsequent long-term follow-up studies, these agents are able to reduce liver cancer, chronic liver failures, and end-stage liver cirrhosis, and decrease the liver cause of death. Now, the problem is, right now, we have 83.3 million individuals eligible for the treatments in 2022. 32% were surface antigen positive, that is, it represents 32% of the surface antigen positive populations. Unfortunately, only 36 million individuals were diagnosed, and what is even worse, only 6.8 million people ever receive any antiviral therapy. So there's a problems here. We have the science, we have the drugs, we have the diagnostics assays. It is easily available, and with the developments of generic agents, especially the nukes, the cost is drastically reduced, but we still have problems. So I think that in 2024 and onwards, what we really need in the field of chronic hepatitis B is to understand how we can bridge the gap between the science, and that is we already developed drugs, which is now low cost with the generics, and also very reliable and rapid testing, surface antigens, screening, highly effective antiviral therapies, and also low cost and effective surveillance available for early detections of hepatocellular carcinoma, which is the only methods to save the patients from dying from hepatocellular carcinoma. So why is it not translating to our patients? A lot of them still left undiagnosed, and a lot of them still left untreated. And those who are treated, a lot of them didn't have any surveillance. Well, people are trying to improve the surveillance methods and trying to improve new therapies. And I think this might not be the major emphasis we should be dealing with, because we already have them. Already have very effective treatments. We already have very good diagnostic assay. We already have very good surveillance methods. It's not really of having a new method that matters a lot. It's really how to translate what we have to our patients. So I think the major barriers hindering the significant reductions of disease burden due to hepatitis B infection is really under treatment of those with a risk of developing complications related to HBV infections, and also a lack of awareness among the publics and policymakers. We have guidelines in the past, which is based on the, what we know at that time. But there is a limitations because with the evolutions of new technologies and understandings, such as the use of quantitation surface antigens, and also the assessments of liver fibrosis with non-invasive tests, and also with the increasing prevalence of comorbidity factors such as the metabolic associated fatty liver diseases, these guidelines might not be practical. And also the ALT upper limit of normals used by the various regional society when they write up the guideline was based on the data they have at that time, which might be limited. So is it at right times for us to revise and to re-understand what this guideline means? A lot of these guidelines, and in fact, the essence of these guidelines is based on ALT level. And recently, published in the Lancet Regional Health by our Chinese colleagues, they tried to use the decision tree Markos state transition models to evaluate the cost effectiveness of expanded antiviral treatments for chronic hepatitis B in terms of ALT, age, time of implementations, and treatment coverage. They simulates 136 scenarios by various ALT treatment initiation threshold, age, sex, and in implementation durations and the treatment coverage. Now, it was shown that expanding the treatments to chronic hepatitis B patients with ALT threshold of 30 and 19 U per liter for males and females respectively would enable us to give 80% treatment coverage for surface antigen positive individuals between the age of 18 and 80 years old. And only with this, we will be able to see 65% reductions in chronic hepatitis B related deaths by 2030. So this really challenges the existing guidelines, which use much higher ALT levels for those patients with hepatitis B. And we are going to resolve the problems. Maybe we should revise our guidelines. I understand those guidelines are dictated by a lot of the very big papers, literature, but having the understanding these papers were really established at a time when our virological assay was really pretty different. Say, for instance, at the time when we do the lamivudine phase 3 studies, the HBV DNA was done by by hybridization assay to assay it is positive or negative. So we have evolutions of the sensitivity of the assay too, and maybe we should really get these guidelines to be modified so that it will fit into our patients. And I congratulate my Chinese colleagues. They are the first ones to really expand the guidelines for the sake of the patients. And this is published by Professor Yao Hong from Beijing in last year, which basically translate what the problem is to our patients. In fact, they advocate the treatments of all surface antigen positive patients, provided they are HBV DNA positive, and if they unless they are ALT completely normal, but without family histories of hepatocellular carcinomas, a greater age, and there is no significant fibrosis and also no extrahepatic manifestations. So this will greatly expand the number of patients with surface antigen positive to receive treatments. In fact, after reviewing all the literature's guidelines and being in the field for 30 years, we recently proposed strategies for elimination of HBV disease burdens. And that is first, a universal screening of hepatitis B patients. We have a quick test. We can give the results of surface antigen positivity in a very quick manner for those patients, just a finger prick. It carries a very high level of sensitivities and specificity. Is pretty reliable, up to 98%. It is really, the cost is really low, because at the time when 20 years ago, when we start to do this community work, the cost is so much more expensive with the quick test. It's cost us 100 Hong Kong dollars, but now it's around or less than $1. So it's a 99% reductions in the cost. And once we know that whether the patient is surface antigen positive or not, we should use an expanded antiviral strategies to treat those patients. We advocate to treat all, except in the presence of any of the two of the following conditions: undetectable HBV DNA, ALT less than upper limit of normal. So we used the threshold of 30 and 19 for males and females, and no significant cirrhosis or advanced fibrosis, and no plans for immunosuppressive therapies, and absence of extrahepatic disease. And we also advocate the use of solid outcome measures, not to talk about surface antigen loss. Not to talk about HBV DNA negativities, fibrosis, and so on. We can easily look at the mortality and incidence of liver cancer by the cancer registry in the regions, because only by looking at these hard endpoints we can adjust our policy, whether what we are doing is translating to benefit our patients. Not to talk about those new functional cure, surface antigen loss, which is not durable. And I think we should really re-emphasize our efforts to bring benefits to our patients. We already have the treatments. We already have the diagnostic assay. We do not really need new therapy, which is so unreliable, as shown by the recent study for the functional cure. So universal screening for surface antigen positive, expanded treatments, and we believe that if we look at the real hard endpoints, that is the mortality due to liver cancer, we will be able to guide our therapy, especially now we are coming to the AI, artificial intelligence, with big data and with electronics devices, we will be able to do it. But it can only be done with concerted efforts. And to this end, we have formed a parvovirus elimination task force, chaired by myself, and also the Professor Martin and SK Sarang. And we have more than 100 active and researchers in Asia Pacific regions who really shows the heart to bring benefit to our patients and not just for citations and publications and for nonsense research. So, in fact, we would now work with the coalitions of global hepatitis eliminations. They are having a meeting in room 6 right now, and the meeting will carry on until 12 o'clock. And we have come together and make a statement and to call to actions, and we mean it. Now it is time to eliminate hepatitis in Asia, and I hope all of you will join our missions and visions together with a parvovirus elimination task force to bring real benefits to our patients. So in summary, the recent data suggests that deviations of WHO goal of eliminations for hepatitis B as a major health threat by 2030, with over 890,000 new hepatitis B cases in 2019 to 2020, and a global HPV-related mortality exhibiting minimal changes. I think, and we believe that it is because of lack of awareness among the public and policymakers, and also undertreatments of those with risk of developing complications. So therefore, reducing HPV disease burdens besides viral eliminations, I think this is a misnomer. In the clearing the service engines, we don't bother with this. I mean, there are attempts, we respect this, but what we should be focusing on is to reduce the mortality and morbidity suffering from our patients with hepatitis B. And the only way is to look at the incidence and mortalities of liver cancer in our regions. So this is my acknowledgement, and I would like to hear some of your questions, and I will be happy to answer this. Thank you very much.
Thank you, Professor George Rao. And I really appreciate your proposal for the elimination of HPV. And yes, please.
Yeah, thank you, Professor. I'm TC Zen from Taiwan. Very nice talk. So I just have a question about the drug adherence if you expand the treatment criteria. You know, the treating Hep B is a little bit different from treating hypertension or DN, because if they lost or follow up, they just have high blood pressure. But if we treat a Hep B patient and then stop by themselves, I think there could be some hepatitis failure or even liver decompensation. So how do you balance between the pros and cons in this kind of situation?
Very good questions. In fact, in the real world, it's tough issues. It's easy to say, but difficult to do. I think this is a huge public health issue. What we need right now for hepatitis B is public health. It's how to connect the science to the public and the compliance issues, the policymakers' issues, and also the physicians' attitudes, the family attitudes. I think and also the availability of the medication. What is the barriers? Is it the cost? Is it the inconvenience? And how they view the gravity of the problems, and how we're going to break the barriers. So there's a lot of questions and barriers in this area. But I think that we should spend more efforts on this, and this will happen if we share the same vision, because we are the propeller for hepatitis B in the field. And if we share the same visions and work concertedly with the parvovirus elimination task force, which we have formed, I think we can do it. And we need more communications, and then come with our policymakers to bring the benefit to patients. Because you see, and one thing is we have to do some calculations. If we are able to do this with the expansions of the coverage of treatments and with compliance, as you just mentioned correctly, we can save the Asia Pacific regions $100 billion in dollar signs. So we would see less patients dying, and especially when they are in the younger age, in the mid 40s, 50s, when they are economically productive, and that would have an impact on the GDP. So I think that if we orientate our efforts in a more positive manners rather than spending so much time on other fancy issues like the functional cure, I think we will be able to do it. So I'm not trying to discourage good science, but so far the functional cure thing is terrible. It's very confusing data, and I would almost make the comments it's almost irresponsible.
Okay, thank you very much. Next speaker, thank you, Josh,
Okay, I think
for your nice
young lady,
presentations. But because of the shortage of time,
Okay.
we can do it later.
Can I ask?
please discuss on the floor, in the floor.
Okay. Then, Dr. Judge, I have one question about.
Sorry, time because of the shortage of time. Please discuss on the floor.
Yes.
Okay, thank you.
Thank you very much.
Thank you. And the next speaker is Dr. Tai-Chun Chen from the National Taiwan University Hospital. And he is now Associate Professor of Taiwan University Hospital. And he graduated in National Taiwan University in 2001. And he got several awards from some research foundations. Okay, Professor Tai-Chun Sen, please.
Yeah, thank you, Professor Yokosuka. Yeah. Ladies and gentlemen, this is my great honor to have a presentation here. Today, my talk is the role of the correlated antigen in predicting the long-term outcomes for patients with chronic hepatitis B infection. I'm Tai-Chun Chen from the National Taiwan University Hospital. Okay, so this is my disclosure. So in the following 20 minutes, I will have a short introduction about Hep B, and I will show you the new biomarker, the correlated antigen, the role in predicting different clinical outcomes, including the HCC and the S antigen and the E antigen seroclearance. And I will also touch upon about the role of correlated antigen in patients with oral antiviral treatment, how it works in predicting liver cancer and post-treatment clinical relapse, and then the conclusion. So I think we have learned a lot from Professor Zhuang and Professor Lao's talk about the natural history of our HBV carriers. We know that either in the E-positive or E-negative phase, the repeated liver injury will cause the cirrhosis and HCC. So that we call it immune active phase in E-positive and or in E-negative. And only one exception is the immune tolerance phase, because at that time, the patient had a very high viral load, but their ALT is almost normal. So we think this patient, they probably do not need antiviral treatment at that time. And we also have a stage called the inactive phase, that the patient have a very low viral load, and they have an increased chance of clearing their surface antigen. So previously, we have two viral biomarkers, that is HBV DNA and the surface antigen. And HBV DNA quantification is very useful because we know the DNA is coming from the cccDNA, the replication template in liver. And for the surface antigen, it may come from two parts. One is from the cccDNA, and the other is from the integrated HBV DNA. So they have different meaning. And according to the previous study, we have learned a lot. For example, from the Professor C.J. Chen study in 2006, we know that a higher HBV DNA level is associated with increased risk of liver cancer. And therefore, we can define the patient into three groups. The first group is the patient with viral load lower than 2,000. We call them low viral load. And for the patient with 2,000 to 20,000, we call them intermediate viral load because their HCC risk is just intermediate. And then if the patient, they have viral load more than 20,000 units per mil, that they have a high viral load because their HCC risk is usually high. And our previous study, we focused on the low survey patient with low viral load. we found very interesting that the surface antigen level about 1,000 units per ml, they can stratify the patient into two groups. And the patient with higher surface antigen level is associated with increased risk of liver cancer. So that's the story of, published about in 2012. And right now we are in 2024. Actually, we have another new biomarker that is called a correlated antigen. It is composed of three viral protein. That is the core antigen and the P22 and the E antigen. They share the common epitope that can be recognized by the antibody. And actually, this correlated antigen is also derived from the cccDNA. So, although right now we have learned where it comes from, but the next work is how can we apply this correlated antigen in the clinical practice, or what is the rule in the natural history of FB? So let's start from the HCC risk. So this is our two examples about how they use a correlated antigen to predict liver cancer. Although they use different kind of cutoff, they found the higher correlated antigen level is associated with increased risk of liver cancer. The study on your left-hand side is from Japan. They also show that the correlated antigen level is better than HBV DNA in predicting liver cancer. But to be noted, the patient number is pretty small. It's about 700 and 200. And the right-hand side is the study coming from Hong Kong. It's about 200. So after reading this data, I have a quick question. That is, can we, if we want to show that correlated antigen is a biomarker in predicting liver cancer, first, I think we should show something similar to the HBV DNA. For example, can we show the positive relationship between the correlated antigen and the HCC risk? And the next question is correlation better than HBV DNA in predicting liver cancer? Because we know both of them are coming from the cccDNA. In my opinion, it should be similar. So if it is not, so can we find any exact rule for the correlated antigen in predicting the liver cancer? So that's my question when I start to do the research about the correlated antigen. So to address this issue, actually we have already established a large cohort. We call it ERADICATE B cohort. We have enrolled more than 2,600 patients, and these patients, they were non-cirrhotic at baseline, and we have a long-term follow-up, and most of them remain treatment naive during the follow-up. Okay, so this is our results. Interesting for the overall patient or inactive patient, we found a positive relationship between the correlated antigen levels and the liver cancer. I think it's pretty similar to what we have seen in the HBV DNA. So the next question is correlated antigen really better than HBV DNA? So according to our data published in 2019, we found either in the 10-year HCC risk or in the 15 years HCC risk. When you look at the blue line and the red line, that is the correlated antigen and the HBV DNA, I think they share pretty similar prediction performance for the HCC. So I think that's reasonable because they are both coming from the cccDNA. So if correlated antigen is not better than HBV DNA, so how can we apply it to the clinical practice? So that's a question I ask myself. So I try to focus on different subpopulation. The first population is the patient with intermediate viral load. That is, they have viral load between the 2,000 and 20,000. Because at that time we know that patient, they only have a moderate increase of HCC risk, which still don't know whether they should treat or not. And according to our data, we can use the correlated antigen level of 10,000 units per ml to stratify their HCC risk. And again, the patient with a higher correlated antigen level is associated with increased HCC risk. So for the first part, the summary is that we think the correlated antigen are positively associated with HCC risk in Hep B patients. And it is not better than HBV DNA, but it can complement HBV DNA level in predicting HCC, for example, in a patient with intermediate viral load. So the following question is, can we expand this application in other E antigen negative patients? So to address this issue, we just move our focus to the patient in gray zone. We know this is a pretty hot topic because right now we know the patient with E antigen negative hepatitis, they should treat. And for the patient with inactive carrier that is marked in blue line, they can receive regular follow-up. But the patient marked in the gray, in a gray, we know they are in a gray zone. They have some kind of mildly elevated viral load and or ALT, but we still don't know what's the optimal management for this group. So, in my opinion, if we face a patient with a gray zone, I think this patient could be a very heterogeneous group. So we need a new biomarker so that we can stratify into the black and white. That means we should treat or not treat these patients. Okay, so to address this issue, we work with a Japanese research team that's from Toronto Hospital. So first, we check our data to see the role of the correlated antigen. So when we compare the correlated antigen level and HBV DNA in predict 10 and 15 years HCC risk, in our data we found the correlated antigen that is marked in blue is better than HBV DNA in patients with gray zone. I think you maybe feel a little bit confused because previously I said they shared a pretty similar performance, but actually in the gray zone patients, they have removed the patient with very low viral load and a very high viral load. So in this case, the correlated antigen is showing its value in predicting liver cancer. So according to this data, we use the same cutoff that is 10,000 units per ml to stratify their HCC risk. We found a patient with higher correlated antigen level is associated with increased HCC risk in patients, in E antigen negative patients in gray zone. Okay, so this is our finding, but actually we try to validate our finding in the Japanese research team. So actually they have a very similar result using the correlated antigen level to stratify their about 500 patients in E antigen negative gray zone, and they have a similar results. So considering this result, we even move further to establish a gray zone HCC score, so that to improve our AURC. So you can see we call it Explorer. So you can use the age, sex, platelet, ALT, and a correlated antigen, so that we can form a risk score. And for example, the AURC for the 10 years HCC is about 0.80 to 0.90. That's pretty good. And more interesting that is its risk score is better than the RICH-B or GAG HCC score. That is based on HBV DNA level, because we know the correlated antigen level is better than HBV DNA. So the correlated antigen based risk score should be better than HBV DNA level. So we use this risk score and we chose the score of A to stratify the HCC risk. So you can look at the figure. The patient with the high correlated antigen level that is marked in green, actually their HCC risk is very close to the patient with immune active, the E-negative CHB patient that is marked in yellow. But for the gray zone patient with the gray zone score less than 8, so their HCC risk is pretty similar to the inactive CHB patient that is close to that is marked in blue. So this same finding is validated in the Japanese cohort. So I think in summary, so in the patients, in inactive gray zone patients, we can use a very simple score called Explorer. When it is higher than or equal than 8, I think we should treat it. But if it is less than 8, should keep observation because their HCC risk could be very close to the inactive carriers. Okay, finally, we will talk about some favorable outcomes. The first one is S antigen zero clearance. So although the Professor Lau says he doesn't like the functional cure, but I will talk something about that. Okay, so we know the correlated antigen is associated with a higher correlated antigen is associated with bad outcome. So we try to explore whether it can also be a marker to predict the surface antigen loss. So basically, this data is just showing that the surface antigen level is still a better predictor, but the correlated antigen, when it turns out to be predicted as loss 15 years or 20 years, actually the AURC is in the figure C and D. The AURC is pretty similar to the surface antigen level. So that makes us some questions. So how can it work so long to predict the surface antigen? So we think it probably work better in a patient with high surface antigen level, because we know it usually takes more than 2 decades to clear surface antigen. So we just focus on patients with surface antigen level more than 1,000 units per ml. And we found there's a dose-response relationship, and the patient with the correlated antigen level less than 10,000 units per ml, that is marked in green, they have a highest chance to clear surface antigen. And I think this study, the most interesting part of this study is showing how the patient clear their surface antigen spontaneously in the natural history. So when we look at a patient with high surface antigen level, before they clear their surface antigen level, their correlated antigen level start to drop about 20 years ago. And the correlated antigen become undetectable about 10 to 15 years ago before surface antigen clearance. But at that time, you can find that the surface antigen level that is marked in green, the surface antigen level is still very high. And it starts to decline maybe 10 to 15 years before S antigen clearance. So I think this story just tells us, okay, at the beginning, when our host immune response to clear the Hep B, they will clear the correlated antigen positive hepatocyte. That means that is the cccDNA containing hepatocyte. But it is still difficult for them to clear the S antigen positive hepatocyte. That could be coming from the integrated form. So it usually take 10 or 15 years more to clear the S antigen coming from the integrated DNA. So I think this kind of story can give me some hint to suggest how we design the cure strategy to clear the HBV. And we also do another research about the E antigen zero clearance. And very interesting, we found the higher correlated antigen level is associated with reduced chance of E antigen clearance. But if their correlated antigen drop from the, for example, from the 10 million unit per ml to lower higher than 10 million unit per ml to lower 10 unit per ml, we can find the chance of E antigen clearance started to increase. So this data will be published tomorrow in the oral presentation. You are welcome to join this research. And finally, I will talk about the correlated antigen in patients with oral antiviral treatment. So I think this is the data from Hong Kong. They show that the on-treatment correlated antigen can predict liver cancer. And this is also the study coming from Japan, from the Professor Hosaka. They also found that the correlated antigen that 1 year after treatment, the higher correlated antigen level is associated with increased risk of liver cancer. So I think this data just tells us that there is some evidence that is showing that higher cccDNA level in liver could be associated with increased risk of liver cancer, even the patient has started antiviral treatment. And finally, I will show you some data about patients who stop antiviral treatment. We all know stopping antiviral treatment could lead to severe adverse event. For example, they can cause some liver decompensation about 1%. So we should be very, very careful. And the correlated antigen can help us to predict some of them. For example, we found a patient with the data is from the I think this is from a meta-analysis of different multi-center study. They found a patient with the higher correlated antigen level that is marked in gray is associated with increased risk of ALT flare, either in Asian or non-Asian patients. So this is my conclusion, and ladies and gentlemen, for predicting the liver cancer in antigen negative patients in gray zone, I think the correlated antigen is better than HBV DNA. And the gray zone HCC score, we call it Explore, so it can identify who needs antiviral treatment. And for predicting the favorable outcome in treatment-naive patients, I think the lower levels are associated with increased chance of clearance of either surface antigen or E antigen. And for the patient receiving antiviral treatment, I think they should play some role in predicting liver cancer and the post-NUC different clinical outcome. So this is my acknowledgement. I would like to thank my boss, Professor Gao, and also the Jiahong Gao and Professor CJ Liu to coordinate this team so that we can have so many research about Hep B in natural history. And finally, I would like to invite you to join this Apostle STC on muscle. So it will be held in June, and all of you are welcome to Kaohsiung. Thank you for your attention.
Okay, yes, please.
I'm Dr. Jazak from Mongolia. Thank you very much for this interesting presentation. I would like to know more about the comparison of HCC risk development as a factor. Have you ever compared with the elevated ALT and correlated antigen amount, quantity?
You mean the predicting performance between the ALT and correlated antigen?
Yeah.
Yeah. Okay. I don't have a direct comparison between two markers because this is one is a viral marker and the other is liver inflammation marker. But I don't know. I don't have the data. Maybe I'll check it later and update to you. Yeah.
All right. Thank you.
I'm Dr. Kamani from Pakistan. Do you have data regarding the co-infection with hepatitis delta and hepatitis B and HCC? Because in Pakistan, 20% of hepatitis B patients have delta, so it's a major problem in our country.
Yeah, I'm sorry. We have a very, very limited data about delta infection. Maybe less than 1% of Hep B patients have delta. So it is not a very serious problem in Taiwan, but I know it's a very serious problem in your country, and we need more research about this field. Yeah.
Sorry, McNeil from Sydney. I just wanted to know what your experience with interferon is with the correlated antigen.
Okay. No, I haven't done the assays about the interferon treated patient. Because right now we don't have interferon right now.
What would you predict?
Yeah, I think there is some data showing that the lower correlated antigen level is associated with increased chance of e antigen clearance. I believe there is some data showing this correlation. Yeah.
Okay. Short question for.
Yeah. Thank you for your information. So, just a quick question about like patient with MAFOD or like obesity. So some data show that like it's higher HbSAg clearance from those patients. So any difference in the in your GJ score and the the correlated antigen performance?
Okay. Yeah. Actually, I don't have the data either. Yeah. So, but I think the because we now in a gradient patient, we have a group of patients that they have very lower than 2,000, but they have elevated ALT, and some of them believe they could be muscle. But very interesting when we stratify this group of patients using the correlated antigen, we also found that higher correlated antigen level is associated with increased risk of liver cancer. So in my opinion, in this group of patients, maybe not all of them are attributed to the muscle. And some of them, it could be they have some elevation and their value is transiently suppressed by the liver inflammation. But in the end, if the patient had higher correlated antigen level, that means they have more cccDNA, I think their risk will increase, especially the liver cancer. Yeah.
Thank you very much.
Okay. Thank you. Thank you very much for your excellent presentation. Thank you. Now I would like to close this session of hepatitis B. I would like to thank all four speakers and the audience from the floor. Thank my co-chair, Professor Yokosuka. Thank you.
Thank you very much, lecturers and moderators. Now we will have a coffee break. Coffee will be served in front of the main hall. The next session will start at 10:50 a.m.